Hello, welcome to the Cancer Informant. I'm Dr. Tony Maliocco, and I'm the Cancer Informant. This is podcast number 3, where we talk about aspects of cancer diagnosis and care of particular importance to cancer patients. The Cancer Informant is dedicated to help patients understand their journey with cancer and the steps that they can take to improve their outcome. I have over 30 years' experience in cancer pathology and cancer diagnosis and treatment, and I'm going to share my experiences and insights with you. Today, we're going to focus on the value of second opinion in cancer diagnostics. Second opinions can be an area of controversy because nobody really likes to be second-guessed or evaluated by another expert. But I think second opinions are extremely important for cancer patients. In episode 2, we spent a lot of time talking about how is a cancer specimen analyzed and how a biopsy is taken to a pathology lab and the role that a pathologist takes in terms of evaluating tissue and also ordering special tests to ensure that the diagnosis is accurate and complete. We also learned that on conclusion of a pathology exam that there is actually a lot of material available that can be reevaluated. So the glass slides are available for another pathologist to look at. The slides may be digitized so the images can be shared. And the paraffin-embedded blocks are also available. So those can be retrieved and additional pieces of tissue sliced off and sent for further analysis. So even if you had a diagnosis many years ago, you could still access that tissue and potentially have additional evaluation of it. This could be very important for guiding future treatment, particularly if your cancer has recurred or persisted from that original diagnosis. But first, let's go back to the original diagnosis of cancer and the value of a second opinion. First of all, we know that the pathologist is very important in first of all determining, do you have cancer or do you not have cancer? And if you do have cancer, what sort of cancer is it? Is it adenocarcinoma? Is it a squamous cell carcinoma? Is it a lymphoma? These are all very important decisions that a pathologist has to make because they fundamentally change the way that your cancer will be treated. Every cancer, every major type of cancer has a different treatment strategy. So lymphomas are treated in quite a different way than, say, breast cancers or lung cancers. Treatment has been optimized to the type of the cancer and also to the type of molecular features that are present in a cancer. So it is of utmost importance that we get that first step right. Carpenters say you always measure twice and cut once. This avoids errors. I like to think that that's also important for patients who have a diagnosis of cancer, and I think it can be very valuable for a patient to seek a second opinion of their pathology. This is not because we believe that pathology is of poor quality, but it really ensures some peace of mind for the patient that their pathologic diagnosis is actually accurate and also that it's complete. So even if the diagnosis is accurate, it may be incomplete, which means that a diagnosis of cancer may be 100% correct, but there may be missing information about is the margin involved or were the correct biomarkers ordered and interpreted correctly. And all of this information is very important for guiding treatment. Many studies have been done to look at the value of second opinion pathology, and it's actually been determined that the error rate is significant and that on reevaluation of pathology that in a low percentage of cases, a diagnosis of malignancy is overturned. And I've seen many cases myself where there was a diagnosis of, for example, a hepatocellular carcinoma. And when I evaluated the liver, it was determined that it actually was a benign lesion of the liver. I've seen other cases where a diagnosis of lymphoma was made and on evaluation, it turned out it was a lupus nodule, a benign condition. These errors are easy to make because pathology is difficult. The specimen may be damaged or hard to read, and if a non-expert pathologist is looking at an unusual condition, they may simply not have the experience to recognize certain aspects about the condition. Further, what's really changing in pathology is that new tests are now becoming approved and are becoming necessary to properly manage cancer patients. And pathologists may not always be completely up to date as the field is moving so quickly. I spoke last time that there can be as many as 50 new treatments approved in a year. And many of these new treatments come along with special tests. So, for example, it might now be important to measure a breast biopsy with an antibody against PD-L1. In fact, this was the case 2 years ago. We had to start measuring PD-L1 expression in triple-negative breast cancer, but then it turned out that the drug that was approved for that particular PD-L1 was then discontinued. What happened, a new drug came along and we needed to measure PD-L1 again, but this time we had to use a different PD-L1 antibody. The first time we used a marker called SP142, which was linked to a particular pharmaceutical's drug. And then when that treatment was discontinued, a new treatment came along, and we had to use a different antibody called SP263 or 22C3 to qualify a patient for a new treatment. So you can see how complex and challenging this is, where the testing can change on a week-by-week basis. And if a pathologist is in an area that may be more remote or more general practice, it may be very hard for them to keep up to date. Now, it's very easy actually for a patient to trigger a second opinion. They can basically ask their doctor to order a second opinion, or they can take it into their own hands and contact a pathologist of their choice or a medical center of their choice and ask, could you please review my case? What typically happens in that case is that a patient would give permission to the new pathologist or to the new doctor to arrange for a second opinion. So when I get a request for a second opinion, what happens is that a patient would sign a consent to me and my team. We would get some information from the patient about what previous biopsies have they had done, where were they done, and who was their original pathologist. We would contact the center and have the medical records sent over to us. So we would review the medical records and we would see what sort of pathology specimens might exist, and then we would retrieve those specimens for review. So the originating site would give us a loan of the case, much like a library. They would send over the slides for us to look at. They would request that we return the slides as soon as we're finished, and they would also request that we write a report as to what we thought the diagnosis was. Some patients are reluctant to actually trigger the second opinion. They're concerned, will my doctor become upset? You might be surprised to know that second opinions are very common, and in fact they're mandatory when a patient goes to a major academic medical center. So if you were to go to an academic medical center, it is very routine for them to have a review of the original pathology. In fact, they may not even arrange to see you with their oncologist until that original pathology has been reviewed. And they know that that review is so important because, one, the diagnosis might change. So it wouldn't make much sense for them to arrange a visit for you with, for example, a kidney doctor for kidney cancer if it turned out you didn't have kidney cancer and that you really had metastatic breast carcinoma to the kidney. You'd see a completely different specialist. So major academic medical centers are well aware that the diagnosis might change, and this is really important to know that before even arranging your first appointment. So it's a very, very first step to really confirm that pathology diagnosis. Also, it's very important to determine if the correct companion diagnostic biomarkers have been ordered and have been reported correctly. So, for example, in breast cancer, we spoke last time, it's really important to measure estrogen receptor, progesterone receptor, and HER2, as this categorizes breast cancer into broad groups. The hormone responsive group, or the luminal AB, these are the ones that have estrogen receptor being present. The HER2 positive, these are the ones that have HER2 being amplified and overexpressed. And the triple negatives. The triple negatives are of particular importance, and they define a very special type of breast cancer that actually often occurs in African Americans and in younger women. This type of breast cancer is frequently associated with inherited genes and is treated completely differently than some of the other types of breast cancer. Now, this diagnosis of triple negative breast cancer is actually kind of challenging because it's really made on the diagnosis of having negative estrogen receptor and negative HER2 status. So sometimes those tests are erroneous. So, for example, if a lab has incorrectly performed the HER2 test or the ER test, they may have a false negative result, which can actually result in an inaccurate diagnosis of triple negative breast cancer, which can lead to a whole bunch of unfortunate consequences and inappropriate treatment, and also missed opportunities to treat with actually active agents. So having this careful examination of whether estrogen receptor and HER2 have been properly tested and whether the results are indeed accurate is really important. This can also be important if only a small biopsy was tested. For example, sometimes in breast cancer, there are multiple biopsies are done. So a very small biopsy may be initially taken. It may be only a few millimeters in size, and that might go for testing. And then a larger tumor might be excised a few weeks later, which is several centimeters. We might find in that original tiny biopsy that the estrogen receptor was negative, but if we were to retest the larger tumor, we would find that estrogen receptor is actually positive, and that this is not a triple negative tumor, it's actually an estrogen receptor positive tumor, and that changes everything. In fact, we also find that sometimes labs make error in testing, that there was something called the breast cancer scandal that happened in Canada back in the early 2000s. And for a period of time, one of the provinces in Canada, the provincial lab, had incorrectly tested breast cancer patients and gave out erroneous results, where the estrogen receptor test was improperly calibrated and improperly resulted, leading to erroneous diagnosis in actually hundreds of women that persisted for many years. And hundreds of women were affected by this, which led to them having incorrect treatment and really a huge problem that required the Canadian provincial systems to look at their entire process of how they certify labs and how they set up new tests. The lessons learned from this are important, that it's very critical that labs take testing extremely seriously, that they be properly accredited, that they're enrolled in proficiency testing programs, and that they actually perform enough tests that they know that their testing procedure is accurate and complete and reliable. So labs that only do a few tests often fall into the trap that their tests may become unsatisfactory or unreliable over time. So having a second opinion and a careful evaluation of the biomarkers is also very important. The third thing is making sure that certain tests are actually done. In lung cancer, it's now important that patients with lung cancer have a molecular characterization. And the molecular characterization involves testing for many genes, not just EGFR. It also includes testing for PD-L1, for KRAS, for various fusions and translocations. So sometimes a lung cancer will only be tested for one or two markers, and a treatment opportunity is entirely missed. These opportunities, for example, MET14 skip mutations or ALK, they are rare, but if you don't test for them, you won't find that treatment opportunity. And if a tumor does contain those particular alterations, there are very specific therapies that are indicated for tumors with those types of alterations that are extremely effective and approved on the guidelines and generally fully covered by insurance. So having the correct testing in lung cancer is extremely important. And we now know that in the community setting, as many as half or more of lung cancer patients are not getting the testing that is actually recommended, approved, and paid for. So ensuring that your testing is complete and accurate is a very important step. Another thing on a second opinion, we might also uncover that a cancer could be hereditary in nature. This could be very important for the management of the cancer, not only for you, the patient, but also for your relatives, your sisters and brothers, and your children. So we may uncover in a colon cancer that, for example, a colon cancer has microsatellite instability. This feature could tell us that this cancer could be part of a disease syndrome called Lynch syndrome. And in Lynch syndrome, if you carry a mutated gene, your chance of getting colon cancer is very high. It could be anywhere from 5 to 10 times the rate of a non-carrier's rate of getting colon cancer. The good news is that you can actually do something to modify your rate of getting colon cancer, and this involves getting colonoscopic surveillance earlier than the usual rate, because in carriers of the, or in people affected with Lynch syndrome, they may get colon cancer as early as their 30s or 40s, much sooner than you would normally do colonoscopic evaluation. So if you know you do carry that cancer-associated gene, you might adjust your rate of screening. You might also have your relatives tested, for example, your children, and if they also carry that altered mutation and increased risk, they might also consider undergoing more increased screening or beginning screening at an earlier age. The other thing is that if you do carry one of these genes and you get one sort of cancer, you may also be at risk at other types of cancer. So, for example, if you do have that Lynch syndrome and you get colon cancer, you could be at risk of getting a second colon cancer. You could also be at risk of getting a cancer of the uterus or other organs. So it's very important that a patient knows the risk. Sometimes the risk can be mitigated. So, for example, in women who carry a BRCA mutation, they may consider prophylactic surgery. For example, as Angelina Jolie promoted years ago, she announced publicly that she had carried a breast cancer-associated gene and had decided to have prophylactic surgery to reduce her risk of getting breast cancer. There can also be procedures done, for example, tubal ligations or oophorectomies that can reduce the risk of ovarian cancer if a woman has gone past childbearing age. So there are many factors that can be taken into account that a second opinion can help uncover. So I would say that having a second opinion does not mean that you don't necessarily trust your primary doctor or your pathologist. It really means that you're being really careful about your diagnosis, that you want to be certain that your diagnosis is accurate and complete. Also, if you go to a center that can actually do a complete second opinion and give you a digital copy of your records, organize the information from the molecular testing, and put together all of the treatment and diagnostic information for you, it can really facilitate your decision on the next steps of your treatment. And in cancer, it's now turning out that a patient has perhaps more than one choice when they consider next steps. They might have options of surgery, they might have options of radiotherapy, options of certain kinds of targeted therapies or immune therapy, and it really helps them if they have their case organized in a portable way so that they could quickly discuss their treatment options with doctors that they trust and that are considering moving forward with treatment plans. So, for example, they may go to a surgeon and have the surgeon review the results of their second opinion to decide if further surgery is necessary. They could go to different oncologists and have opinions about how a different oncologist might decide to treat a particular type of cancer. And it may surprise you that different oncologists may have different approaches to how to treat a cancer, particularly if the cancer is a bit unusual or if it has advanced beyond standard guideline-based therapies. So I would always say to a patient, there's no harm in getting a second opinion. It will give you peace of mind. It will help you organize your results. It will help you seek additional opinions from other medical experts like oncologists and surgeons, because your pathology will now be very solid, will be very complete, and will be available to guide your future therapy. So thank you very much for joining today to hear about the value of second opinion pathology and about how easy it is for you to do that. Also, I would strongly encourage you that this is not an unusual thing to happen. Pathologists are very accustomed to having second opinion. In fact, it's quite useful for a pathology department to have many of their cases undergo second opinion and to have the results come back. It's considered a type of quality assurance where when those second opinions come back to the department, they can keep track of it, and on their annual or biannual inspections, they can show, look, 200 cases went out for second opinions, and our accuracy was very high, that when an expert reviewed, it was 90% concordant. So pathology departments are generally very supportive of second opinions, and it's not uncommon at all. So I would encourage you to consider that, as it's a very important first step in your journey with cancer, to actually confirm, do you really have cancer? What sort of cancer is it? And you have all of the information you really need to guide the next steps in the journey of selecting treatment. So thank you so much for joining us at the Cancer Informant today. It's been a pleasure talking to you about the value of second opinion pathology. Please reach out to us if you have any questions on this. If you have any topics you'd like us to cover in future episodes, please visit our webpage and leave your remarks there. And I hope you all have a wonderful day. Look forward to the next episode of the Cancer Informant. Take care. Bye-bye.